So good afternoon, everyone. Our topic for today is exploring the use of LSD. Um, so we've kind of talked about a few different topics. We looked at MDMA and ecstasy. We've also looked at microdosing of psilocybin. Um, the resurgence of interest in psychedelic medications has been kind of a long time coming. And this is really trying to cap off some of the other psychedelic medications and what information there is out there. And I could make this one a little more colorful than the last one because I figured if I was doing a presentation on acid, I might as well lean in, right? So our objectives for today, we're going to describe the pharmacologic actions. So what is it that lysergic acid diethylamide, so LSD, what does it actually do? What are the effects that are reported from it? We're going to look at a list of proposed conditions that LSD has been considered for. It is everything I am talking about is off-label. It is not officially approved for anything, but it is being investigated in a few different areas. There wasn't as much information as I had expected, so we'll talk about some of the theoretical and exploratory purposes as well. What information is available, we're going to take a look and evaluate the literature. More focused on the efficacy, there wasn't quite as much safety information there. So lysergic acid diethylamide, LSD. LSD is actually a synthetic compound that has been derived from a natural compound. The natural compound is lysergic acid. It's a fungus that's found on rye grain. And it's actually that brown little thing, the picture in the upper right-hand corner of your screen, that fungus that attacks the rye grain produces chemicals, including the lysergic acid. It was purified and identified by Albert Hofmann in the 1930s as they were looking at all kinds of different compounds. When individuals had ingested some of these fungi in the past, they noticed that they did have psychological effects to them, and they were hoping to identify things. He was a chemist that worked for a pharmaceutical industry, and they were hoping to identify compounds that they'd be able to use in future drug development. It really sat around for an extended period of time in the 50s and 60s. It was used a little bit in combination with psychotherapy. However, its use recreationally really took off. And with the stigma associated with that, it really put the brakes on using LSD for anything of a medicinal purpose. The names for LSD, so acid is likely the one that's most commonly thought of. It's also called dots, microdots, Lucy, tabs, and there's a handful of others. LSD itself is a white crystalline substance. It's very, very hydrophilic. You can put it in a solution, and it's really potent. So a minimum dose that creates some physiologic effect is 25 micrograms. The regular dosing that individuals take when they take one of the tabs tends to be between 100 and 200 micrograms, but there are reports of individuals ingesting milligrams worth, so 100 times of that dose in some instances. Most of the time, this compound is diluted into a solution. The solution is then put usually on blotting paper because the blotting paper can have all kinds of different designs on it. There were a couple on the first opening slide. There is some here as well. Individual manufacturers who are illicit manufacturers can have their own particular design or something that designates that that's one of their products. It also has been made into, so the liquid itself, the solution can be ingested. It's been added to tablets and capsules, but by far the blotting paper tends to be, or even on sugar cubes, they can put the solution on a sugar cube and allow that to dissolve. So the oral ingestion that way tends to be by far the most prominent. What LSD is thought to do is a couple things, and we're going to revisit this a little bit later. So it's thought to decrease the firing of the serotonergic neurons, so the 5-hydroxytryptamine serotonin neurons. By decreasing the serotonin neuron firing, it may decrease some of the serotonin overall, which is slightly opposite because we think that it has a lot of serotonergic activity. So the role that that plays is still kind of out with a question mark, but that was identified in most of the papers that I looked at. More prevalent and where we've done much more investigation is related to the agonist activity. So it appears to act like serotonin on a number of different serotonin receptors, the serotonin 1 receptor and the serotonin 2 receptor appear to be the two of greatest interest. Serotonin 2A and 2C are the ones where it seems to have the highest affinity, although it has affinities for many, many of the serotonergic receptors to varying degrees. So with that action, what might we actually see in patients who take LSD? Most of the patients who take LSD are looking for some of these effects: an altered time experience, potentially some degree of removal from reality, feelings of euphoria, changes in sensations and perceptions. The perceptions can end up creating hallucinations. Both visual and auditory hallucinations have been reported. Easy for me to say. Nicole passed it along. Thank you. The synesthesia. So actually experiencing things with different senses. So sometimes people feel like they can touch color or that they see numbers. So that the input from some of their senses actually is kind of overlapping with other senses that they have. Many of those, the altered perception of time, those are some of the responses that they're looking for. So something that removes them from current reality. A number of the resort wellness retreats, what have you, that use LSD therapeutically try to use that. They try to tap into change sensation, changes in the processing, attention and concentration of your thoughts, and to really lean into some of those, decrease the feelings of well-being, to plant the seed for, different motivations, or to enhance the mystic or spiritual effects that many of the users do report. That's not all of the effects of LSD. Patients can become incredibly confused. Some patients don't tolerate it well. We can see headaches, nausea, vomiting. It does appear to have some stimulatory effects. So we see things like facial flushing, sweating, heart palpitations, as well as tachypnea, so increased respiration rates, and then also pupil dilation. There have been reports in animal trials of excessive doses of LSD resulting in seizures, in paralysis, as well as in respiratory failure, but there have been no reports of human fatalities from LSD alone. When LSD is combined with other agents, including stimulants, we have seen more toxicity, but LSD alone has not been reported to be potentially fatal at this point. There's all kinds of commotion in my background, so if you hear that, I apologize. So concerns with use. Other than the stigma, one of the biggest concerns is the potential for a bad trip. So users who are using LSD, they refer to the experience as a trip. Individuals can have hallucinations, but if the hallucinations are disturbing, it can be incredibly traumatizing to the individual. They then have to wait for the 6 to 10 hours for the effect of the LSD to wear off. And some of the hallucinations may add into each other. While most individuals will have changes in their mood, which tends to be euphoria, some people become incredibly depressed. Some people become incredibly anxious. Panic attacks are relatively common. So in the few instances that we're going to look at, all of the individuals who have been given LSD are given it in a very supervised environment to make sure that if this does happen to those users, that they're able to intervene. For individuals, regardless of whether or not they have a bad trip, they can have flashbacks. If it wasn't a bad trip, the flashbacks may be somewhat entertaining, remind them of that experience. But for those who did have a more difficult trip, those flashbacks can be problematic, resulting eventually in the diagnosis of PTSD in some individuals, depending on what the level of distress that that person was exposed to. The other concern that has been raised with the use of LSD is increasing symptomatology in patients who had existing psychiatric conditions, psychosis being the primary one, where it's been noted a number of times that patients have used LSD, they experienced the hallucinations, and then subsequently went on to develop either psychosis or schizophrenia that then did not, it was not necessarily just drug-induced. So it really seemed to kick off some of those symptoms that then remained. It also appeared to destabilize patients who previously had an anxiety disorder, even if they hadn't had a bad trip. And that may be due to all of that serotonergic activity. So people are using it. They tend to be, the usage rates of it have remained surprisingly relatively consistent with small degrees of variation since the 1970s. So it's not one of the most prominent illicit substances that's used, but there is a subset that consistently uses it. And that's been documented by the Drug Use and Health Survey that's done by the NIH on a regular basis. So even though that use hasn't fluctuated as much as we've seen with some of the other agents, there is some interest in looking at, can we change LSD's use into something more therapeutic? I had expected one thing, and maybe that was my fault going into this with a set of expectations. And what I found was something fairly different. So the conditions that I was able to find that have been associated with LSD use are alcohol use disorder, autism spectrum disorder, and anxiety related to palliative care. And those are the three we're going to look at specifically with literature. The rest were all proposed uses where there may be a couple case reports or in most cases more anecdotal information that yes, this has been reported, but not necessarily published in a traditional standardized way. So the other conditions that they were looking at was Alzheimer's disease, atherosclerosis, which threw me a little bit because I wasn't expecting that one to be in there, anxiety disorders, migraine and cluster headaches, as well as multiple sclerosis. Now, these other ones all have asterisks next to them. So I found in multiple locations that it's proposed that maybe we could use this more from a theoretical background. And there is a ton of interest in looking at LSD because of its potential role in inflammation. So the rationale behind all of those was because there appears to be a link with the use of LSD and anti-inflammatory properties. Now, as they start to look at this, they did identify that in inflamed tissues, they find higher concentrations of serotonin and higher density of serotonin receptors. It should be noted, as my little bubble off to the side says, it's not really clear whether that's because it's inflamed, the serotonin caused that, or if it's a result of there being inflammation that the serotonergic tone has been upregulated to try to get control of the inflammation. Because serotonin has also been associated with neuroinflammation. And there are a number of laboratory tests that have been done and are currently ongoing If you're interested in this area, it's really fascinating. They've done a lot of exploration to try to determine the interplay between the serotonin 2A receptor and inflammation. It is not a direct relationship. They're trying to uncover all the steps of the cascade. One of the relationships that they've been able to identify and describe is that the activation of the serotonin 2A receptor can actually lower concentrations of the tumor necrosis factor alpha, so TNF alpha, which has been identified as one of our inflammatory cytokines. It's involved in a number of different inflammatory conditions. It surprised me a little bit that I didn't see as much pain, but definitely some of the other conditions, multiple sclerosis, potential neuroinflammation with Alzheimer's disease. There is a subset of receptors that appear to be more prominent on blood vessels and the resulting inflammation of those blood vessels leading to atherosclerosis. So that was really where that came in. There's not a lot of clinical data. There's quite a bit of in vitro lab investigations looking at, well, if we expose them to this, what happens to a number of the other chemicals? And it's starting to move into some of the non-clinical animal studies. So more to be found here, but that's really kind of the direction that things are moving in, not so much in just using LSD itself. And I wanted to do that because most of the conditions I found really didn't have the evidence I was hoping for. For the evidence that we do have, substance use disorder, alcohol in particular, has the most robust amount of data and support. LSD is thought to be used in combination with psychotherapy to help elicit different insights, to help patients gain a better understanding of their behavioral patterns, and ultimately to generate motivation for them to continue on their pursuit of sobriety and recovery. So this particular article was a systematic review. It used some fairly specific criteria. There were about 20 trials that investigated LSD use and alcohol use disorder. This only included 6 of them because of the specific information they were looking for. Many of them did start in the 1950s and 60s. So from a methodological standpoint and a data standpoint, we don't have as much as what we see with some of the newer trials. These 6 trials did encompass more than 500 adults. Those who received LSD were about 61% of those individuals, and the control group was about 39%. And I did want to say something about the control group. So control is not necessarily placebo. So the control group, in some cases, was not given a drug intervention, but in many cases, they were given a medication. So for one of the trials, they received 60 milligrams of dextroamphetamine. Another trial, they received 60 milligrams of amphetamine. And then the remaining trials included a control of 25 to 50 micrograms of LSD. So they did receive LSD, but just a lower concentration. For those who were in the LSD groups, the dosing for that was anywhere between 210 milligrams. Not sure why it was 210 and not 200, but 210 up to 800 milligrams per dose. In each of the trials, they were only administered 1 dose of this. All of the patients were inpatient. There were more men than women. On average, they were in their early 40s. And they all had been inpatient for treatment of alcoholism. So most of the diagnosis were using the DSM-1 and DSM-2 criteria. So what they found was between the 2 groups, improvement in alcohol misuse. So they were trying to capture how much alcohol they were drinking, how frequently they were drinking. And as they looked at this, they did it a couple weeks after they were discharged from the hospital. Then they looked 2 to 3 months after that first follow-up, 6 months after that first follow-up, and 12 months after that first follow-up. At that Couple week time frame, the improvement in alcohol misuse was 59% had improved in the group that had gotten LSD and 38% had improved in the control group. As they followed them more long term, they did not give us percentages, but we did have odds ratios. And what they found was short term, the improvement in alcohol misuse was in favor of the group who got LSD. So their odds ratios were between 1.96 and it dropped to 1.66 by that 6-month mark. So it did appear that they were less likely to misuse alcohol if they had had LSD as an inpatient, but it wasn't sustained. By the time they got to that 12-month long-term follow-up, it was no longer statistically significant. When they looked at patients who were completely abstinent, so not drinking alcohol at all, again, we saw improvement in the LSD group a couple weeks after discharge with an odds ratio of 2.07. The short term, so 2 to 3 months later, it was still significant, but this one fell off by the time they got to the 6-month follow-up. So it appeared that one dose with limited reinforcement of the psychotherapy did improve the use of alcohol, the misuse of alcohol short term, but not necessarily long term. So there is some interest in starting to look at this and have this incorporated a little more systematically to improve those longer term outcomes. From an adverse effects standpoint, there were a handful of adverse effects that were reported. Agitation and bizarre behavior were the most frequent, and that was in less than 5% of the patients. There did not appear to be bias because individuals did not necessarily know if they had been given LSD or one of the other compounds, at least according to the authors. And that's likely because the control group wasn't a placebo group. They were given something. So they may have felt something, but not really known exactly what that was. So that may have been relatively helpful in preserving some of the blinding there. I have to admit with the 800 milligram group, the average dose was 500 micrograms, not milligrams. 500 micrograms was the average dose that was given. That's much higher than what the traditional dose was noted to be. So I was really surprised they didn't see more tolerability issues. There was one patient who had a seizure. However, it was not thought to be LSD related. It was thought to be related to his alcohol withdrawal because he continued to have seizures even after he had been on the off of the LSD. So maybe there may be a role for it in the treatment of alcohol use disorder. And looking at some of the other conditions, autism spectrum, this one may be a little sad. This was a compilation of historical reports of the use of LSD in kind of a pseudo-standardized way in central New Jersey for kids who had autism spectrum disorder. There were reports that, hey, this might help. And it seemed that they were giving LSD indiscriminately to some of the patients at the time to try to see if it would assist with some of their symptoms. And a couple of the small trials that were done, they would dose kids who had autism spectrum disorder when they got to school. They were given doses of 50, 100, or 200. I see Nicole's face. Yeah, it was interesting. So they gave the kids 50, 100, or 200 milligrams of LSD when they first got to school, but then they monitored them throughout the rest of the day. So they had kind of a shadow for the rest of the day. The changes that they noted in these children were decreased physical mannerisms. So if they had flapping or rocking, those had decreased. There was an increase in physical contact in between the students. They appeared to have some altered physical sensations. They said specifically with their face and their lips, because there was much more touching of their face and lips. But they saw some pretty significant mood swings from euphoria to anxiety, agitation, and outright aggression. And there also appeared to be evidence of hallucinations, with some of the children responding to things that weren't there or responding strangely to objects that were there. They did not systematically collect adverse effects. Many of these kids were nonverbal. So they said there weren't many, although I'm not sure that we would know if there were. The outcomes weren't standardized. They really were just kind of comparing each child's behavior, and they took some of the averages of what they saw. Because of some of the stigma related to the use of LSD, and the investigators really were doing this in a hope that they could improve some of the verbal communication. That was not one of the changes that they saw in any of these trials, so it was abandoned at this point for the use in autism spectrum disorder. I haven't seen it come up too much. There's a little bit of discussion, maybe if LSD can be helpful with inflammation, it might be helpful with autism spectrum disorder, but it's much lower on the list of potential targets. So the last condition where I was able to find a little bit of information, they were looking at the use of LSD as part of palliative care. So not as comfort care, but to help with the distress of patients who were closer to end of life. So this was the results of a phase 2 double-blind placebo-controlled trial. They took patients who essentially were hospice palliative care end of life due to life-threatening conditions. They enrolled them in this program, in this trial. So they were either given LSD at doses of 200 micrograms, or they were in the control group and they got the smaller dose, so 20 micrograms of LSD. They had psychotherapy sessions, so there were at least 2, sometimes 3 psychotherapy sessions as preparation. Then they would have their intervention with the therapist, so their session as they're taking the LSD or the control. And then they would have integrative psychotherapy sessions, and all of those sessions lasted between 60 and 90 minutes. They did repeat the active dosing twice, and it was about 3 weeks apart. So they didn't want them right back to back. They then did a follow-up 2 months after the last active treatment dose, and then 12 months after they had had that dose. For the control group, they did allow patients to move into the more active group and get the full dose of LSD if they were interested. They did that after that first follow-up, or after their last session, because at that point they then had unblinded them. What they found, their primary outcome that they were looking at is the state trait anxiety inventory. So this is a 40-item self-reported anxiety scale. It's a Likert scale, 4 points. 20 is the lowest, 80 is the highest. 38 really is the threshold where we start to see more moderate anxiety. So as you can see, most of these individuals did have moderate to severe anxiety. They were end of life. The hope was this would be part of the psychotherapy to help alleviate some of the distress that they had with their impending death. They did not see a difference between the 2 groups. So statistically, there was no difference. While it looks like it was trending down, they also were getting psychotherapy sessions on a regular basis. There was a follow-up study that was noted in another paper, but it's not published anywhere, at least not yet. It followed a very similar methodology, and they said statistically they did see a difference, that it did reduce the anxiety that was seen in some of those patients. So potential option, maybe something for some of the individuals who are in very acute distress as part of more of a standardized protocol, but not robust data at this point. So that's our LSD story up to this point. Recreationally, it continues to be used on a pretty consistent basis. And even though they're exploring a lot of other options, we really have limited therapeutic options that they've systematically explored. And alcohol use disorder does appear to be the one that's best placed to have this as an intervention moving forward. That's what I got for today. I will stop my share and turn it back over.